Hello, my name is Ken Chevli. I'm the site director for urology for Kaleida Health, Millard Fillmore Suburban Hospital. I'm also the chairman of University of Buffalo Department of Urology and the president of Western New York Urology Associates and Cancer Care of Western New York. Today we're going to talk about prostate cancer because September is Prostate Cancer Awareness Month, and there is no better time to talk about it than now. We are going to talk about prostate cancer, its risk factors, how we screen for prostate cancer, how we determine the aggressiveness of the cancer, the treatments of the cancer, the side effects of the treatments, and how do we deal with advanced cancers. First of all, prostate cancer is the most common cancer in men. It's the second leading cause of cancer-related death in men. Although it is common, most cancers are caught early and are highly curable. The risk factors of prostate cancer, including advanced age, men who have a first-degree relative with prostate cancer, and African American men also have a higher risk of developing prostate cancer. There is a somewhat of a correlation between smoking and obesity, but not nearly as much as age, family history, and race. So how do we identify if a patient has prostate cancer or should be evaluated for having the cancer? There's two important screening tools. One is a digital rectal exam. Second is a blood test called prostate-specific antigen, also referred to as PSA. The PSA blood test does not have a exact normal value that you need to be under. There's a range of PSA depending on the age of the patient, but also what we really look at is the change of PSA over time. The PSA also goes up by the size of the prostate, so there's multiple variables that your urologist will use to determine whether or not your PSA is abnormal. If the PSA is abnormal or the patient has an abnormal rectal exam, the clinician will likely ask for a prostate biopsy. What that entails is an ultrasound probe is placed into the rectum where he can visualize the entire prostate. Lidocaine, an anesthetic agent, is injected into the prostate and multiple samples are done through that needle. Those samples are typically done randomly. To improve the accuracy, the clinician may also ask for a prostate MRI to be done beforehand. After those samples are taken, they're sent to a laboratory to be examined to see whether or not cancer exists. If a cancer does exist, the clinician is going to use words such as Gleason score or Gleason grade group. Those are very confusing terms, but let me try to simplify it. Gleason score is a number from 6 to 10. The higher the number, the more aggressive the cancer is. Gleason grade group is a similar scoring system, but it goes from 1 through 5. Similarly, higher the number, the worse the cancer is. This slide depicts what I'm talking about. The Gleason score is determined by looking at two clusters of cancer cells in your biopsy specimen, the two largest clusters, and the pathologist will give it a score between 3, 4, or 5. And they'll add two areas together. That's why the range is between 6 to 10. Gleason 6 cancer is the least aggressive, whereas Gleason 10 cancer is by far the most aggressive cancer. Now, as you can see on this slide, in the middle, Gleason 7 can be obtained from a cluster of cells that have Gleason grade 3 or 4 combined. But if 4 is more dominant, then it's 4 plus 3. If 3 is more dominant, it's 3 plus 4. What that does is changes the grade group. 3 plus 4 is less aggressive than 4 plus 3. I know it's a subtle nuance, it's confusing, but it does affect the way you are treated. Once again, grade groups, which is in the right column, goes from 1 through 5. 1 is less aggressive, 5 is high aggressive. Once we know what the Gleason groups are, we can then determine what is the risk this cancer is on the patient. What is the risk that this cancer is going to cause harm, meaning spread, metastasize, or even kill the patient? And we put these into 3 simple groups: low risk, intermediate risk, and high risk. And those risk categories will then determine on how we treat the patient. So what are the treatment options? They can range from surgery to radiation to even monitoring, which is not even treating the cancer. So I'll go through these briefly. Surgery involves taking out the whole prostate, and now we do this robotically. It takes about 2 to 4 hours to do. You're in the hospital 1 day typically. The patient will have to have a catheter for 1 to 2 weeks. And after the catheter is removed, initially there could be some bladder control issues, but those control issues come back very quickly. The prostate is completely removed and can be analyzed, and we can then see whether or not any other treatments are necessary. Radiation involves daily treatment, Monday through Friday, for a variety of weeks depending on the situation. It could be 3 weeks to 9 weeks in length. Brachytherapy is another form of radiation therapy where these radioactive seeds are implanted in the prostate. Those are typically outpatient procedures, but the radiation is active for many months afterwards. High-intensity focal ultrasound therapy, also called HIFU, is typically used for a part of the prostate is treated, not the whole prostate. It's not generally considered standard of care, but we do it in select cases. Same with cryotherapy. Cryotherapy, as the name implies, is freezing the cancer, where little probes are placed into the prostate and destroys the cancer by freezing it. Hormone therapy is typically done for advanced cancers, and we'll talk about that in a future slide. Active surveillance, which is the last item on this menu, is actually one of the most common things we do now because we find these cancers so early. And if it's a slow-growing cancer, we may just monitor the patient because many times patients will not be affected by their cancer and will not have to suffer any of the side effects which are potential from these treatments. So what are these side effects? From surgery, urinary incontinence and sexual dysfunction are the most common risks. Urinary incontinence almost always is self-limiting, lasting from a few days to a few weeks. Sexual dysfunction ranges from permanent to not at all. Again, it depends on several situations. However, if erectile dysfunction does occur, we do have other therapies such as oral agents that can help with improving their sexual function. Radiation therapy similarly can have urinary problems and erectile dysfunction, fatigue, and some bowel problems, but those symptoms seem to go away soon after the radiation is completed. Brachytherapy is a form of radiation and has those same sort of side effects. High-intensity focal ultrasound and cryotherapy can cause some dysuria, which is burning on urination, and some control problems while the patient is going through the healing process. Hormone therapy, which is an injection that's typically given between every 3 to 6 months, suppresses the male hormone testosterone. It's used for some forms of radiation therapy, but also used for advanced prostate cancers. That therapy can result in sexual dysfunction because of the loss of testosterone, but also because of the hormone changes, men often experience hot and cold flashes. Those are usually self-limiting, but if they bother the patient enough, there are medications to help take care of that. Of course, if we do nothing, which is monitoring with active surveillance, there are no side effects to that other than we do need to keep an eye on the patient. We will see the patient typically every 4 to 6 months with blood work and rectal exam, and maybe once a year with an MRI or maybe even a repeat prostate biopsy. What do we do when the cancer has spread? That is advanced prostate cancer. We have special clinics developed specifically for that. In fact, the only one of its kind at Millard Fillmore Suburban Hospital. The Advanced Prostate Cancer Clinic deals with the complex treatments that are needed for managing this disease. That includes hormone therapy, both the injections, but also some novel medications. These medications are quite expensive, and extensive approval process is necessary to get them to the patient. And these clinics also have the ability and access to these medications for those men who have difficulty with financing or do not have an insurance plan that will cover them. Chemotherapy is also an option. These therapies are readily available and will be coordinated by the doctors at the Advanced Prostate Cancer Clinic. So, in summary, prostate cancer is the most common cancer in men. If caught early, it's highly curable. Many men do not even need to be treated, but running away from this is not a good strategy. Get checked on a regular basis. Either call Western New York Urology or Cancer Care Western New York for any questions. Thank you very much for joining us today, and see you at the next HealthyU.